Right, good afternoon. Welcome to the meeting of the Health and Adult Social Care Scrutiny Panel. Huddersfield Town Hall. I'm Councillor Bill Armour, lead member. And if we'd like to start with the membership of the panel, I'll start here if I may.
Thanks. Hi, I'm Kim Taylor and I'm a voluntary co-optee on the panel.
I'm Councillor Beverley Addy for the Combe Valley, a member of the panel.
Hi, I'm Jo Lawson, councillor for Crosslandmore and Neverton Ward and a member of the panel.
Hi, I'm Councillor Habib Anzaman, councillor for Batley East Ward and a member of the panel.
Hi, I'm Itrat Ali, councillor for the Murfield Ward and member of the panel.
Thank you for that. I believe we have some apologies.
Yes, we received apologies from Councillor Leslie Warner and co-optee Helen Clay.
Thank you. Item 2, have we all seen the minutes of the previous meeting? Anybody wish to say that there are problems or issues with them? Yes, please. I'll be bummed, yeah. Oh, you approved, that's fine, that's what I thought you were saying. There an issue with them. So we move that we approve them. We've got a seconder for that. Seconded, Councillor Ali. Thank you. Declarations of interest. Members are asked to say if there's any items on the agenda in which they have any disclosable pecuniary interest or any other interest which may prevent them from participating in a discussion. Have we got any such interests?
I hold a bank contract with CHFT.
Thank you. No one? Thank you. Item 4, admission of the public. This is a meeting held in public. It's a public meeting held in public. I don't actually think there are any members of the public here. We do have representatives of several organisations. Do we have any deputations or petitions?
None received, Chair.
Thank you. Similarly, we don't have any members of the public to ask questions. Item 7, Older People's Inpatient Mental Health Services Transformation Programme. And as lead member, I attended an informal meeting of Scrutiny colleagues and officers from Calderdale and Wakefield councils on the 4th of July to consider whether or not the proposals for changes to inpatient mental health provision for older people, as outlined in the document back here, were likely to amount to a substantial development or variation in service provision. The consensus of that meeting was that this is indeed likely to be the case. It's for the panel to consider whether or not to proceed to authorise officers to work with their colleagues from the other authorities to implement a formal joint health overview and scrutiny committee, as outlined on page 11 of the document pack. My view, having taken advice, is that because the NHS see this as a major change, that we really ought to go along with that. We ought to take their advice, but it's a matter for the panel. So have we got any comments on that?
I would agree that it's a substantial change and have big impact on the people involved, and will need careful consideration as how it can be implemented to best meet the needs across the whole area.
Yes, thank you. Anyone else wish to comment? No, I think to some extent we have to follow the lead of the provider. They say it's quite a major change, and Scrutiny colleagues, certainly in Calderdale, think it needs to go to joint. They've already, I believe, made a decision on and Wakefield colleagues were very strongly in favour of it. I'm not sure whether they've made a decision as yet, but that's the way it is. Do we have a proposal on that one?
I move that we go ahead with the, follow the colleagues we have and go ahead with the implementation of a JOSC for this.
Seconded. I'm sorry, Hamid, I nearly got twisted with your name there. My apologies. So that's proposed and seconded. And who's in favour? So that's the unanimous decision. Thank you. Moving to item 8, resources of the Kirklees Health and Adult Social Care Economy. As members are aware, I had an earlier briefing with Mr. Parry, who's the Strategic Director of Health and Adult Social Care in Kirklees Council, on the 2nd of August. Our committee officer, Yolandi Myers, joined this meeting as note taker, and I will ask her to share her notes in a moment. A particular area of concern for me is the financial health of the local independent sector, where because there are many relatively small providers of nursing and/or residential care, it's not always easy to gain a clear picture due to issues of commercial sensitivity. I was reassured to hear that overall there is an excess of capacity over projected demand at the moment within Kirklees as a whole. But there are local pockets where the supply is very tight, and it may be necessary for prospective clients to look further afield beyond the immediate area in which they have been living. This panel has no direct relationship with such independent service providers, but our interest here stems from the fact that Kirklees Council has ultimate responsibility for ensuring the welfare of vulnerable residents. So if Yolandi would like to share the notes of that discussion, please.
Thank you, Councillor Lam. I think you've nicely covered the main themes of it. Our Strategic Director for Health has outlined some of the national pressures that's increasing demand for pressures within Kirklees, and that is around people coming out of hospital much more iller or more ill than they were before. There's also the increasing pressures to the council for the national living wage, difficulties in terms of the workforce, how retail, I think none of these are kind of new to the panel, I don't think. Retail wages pay much higher than what would be paid in adult social care. The challenge around people's increased frailties following COVID, and the fact that during COVID that perhaps those ones who were frail got more frail because they couldn't do the usual daily routines perhaps that kept them much more physically well than they are now, so that's increasing the pressure. In terms of residential homes, the bed occupancy rate, well, there were 700 empty beds during COVID. That's now down to 200, with pockets of places where there is little provision. So that's not evenly spread. So there are some concerns around that as well. And then also he mentioned in terms of adults with learning disabilities, or those with quite complex needs requiring high intensity staffing levels, and the increasing budget demands on adult social care. So that's something that perhaps we can come to the work programme, we can see what you want to do in terms of addressing that.
Yes, thank you. And Mr. Parry is not present today, so I think we know where we are with that. Have we got any commentary from the panel? Anybody wish to speak on that? No? Right, so I think the position we're in is that we just note the information. It's something that we are aware of, it's an issue that we will keep an eye on as we go forward. Thank you. And moving to item 8, resources of the Kirklees Health and Adult Social Care Economy. I do believe we have some presentations here. We certainly have quite quite a bit of detail in the document pack, so there's a fair bit to get through. So who's wishing to start off with this, please? If you'd like to introduce yourself.
Thank you, Chair. Would you like us to do introductions so that everybody knows who we've brought with us? And we're also missing a couple of people. Let's go first.
Yes, that would help me as well.
I have to say I'm not used to these buttons. My name's Alison Needham. I'm Operational Director of Finance for Kirklees ICB. I'm currently acting place finance lead for Kirklees.
Vicky Dutchburn, Director of Operational Delivery for Kirklees Place.
Catherine Wormstone, Director of Primary Care for the ICB, Kirklees Place.
Thank you. Oh, sorry.
Sorry, that's Johnny Hammond, Chief Operating Officer at Calderdale and Huddersfield Foundation Trust.
How can I ignore the Chief Operating Officer? My apologies.
There are some more this side as well.
And we've got some more, sorry.
I'm Musrat Khan. I'm the Cabinet Member for Health and Adult Social Care.
Yes, thank you.
Michelle Cross, Service Director, Kirklees Council.
Thank you.
Rachel Foster, I'm Assistant Director of Operations for Locala Community Services.
Thank you. Right, who's going to start? With
If I start, we've got Chris Lennox on screen as well from Mental Health Trust.
Yeah, sorry, Chris Lennox, Director of Services for SWIFT, South West Yorkshire Mental Health Trust. Thank you.
And we also expect Jackie Tatterton from Mid Yorkshire Trust at some point as well, if she gets here. So what we've done is, for those that may recall, we did a very detailed presentation last year that went into a lot of detail following the recovery plans that we had coming out of COVID. So what we did is we took the same principle and we've updated that and brought that up to date for yourselves this time. So we circulated a pack that I think was roughly about 60 pages of detail, but it specifically answered all the questions that we'd been asked and brought that up to the present date for you. What will be on screen that Yolanda's going to put on for us to go through is a much shorter slide pack, which is a summary version that we'll split into two sections. So the first section Alison will go through, which is the finance section, and then the second element is the specific demand and capacity, and then we're open to questions. So we've summarised it so we can take more questions.
Thank you, everybody. Just to reiterate what Vicky's just said, we provided quite a comprehensive overview of the financial system of Kirklees last time. We talked a lot around how we've come together as a system. I can see the benefits coming to fruition of that, working really closely around how we work together around finances and how it ties in with just patient, has to be, and outcomes, which has to be at the forefront of everything we do. What I'm just going to do is probably give you a quick overview of where we're at now, and I can talk through anything you need. Just to note, my focus predominantly on the health sector. Michelle will probably go through the sort of the finance of health of local authority if I can't answer it. Okay. So what I just wanted to go through is we are now part of a West Yorkshire Integrated Care Board, as what used to be the Kirklees CCG. It was created in July 2020, and now we're no longer a statutory body as an ICB. So we report up to West Yorkshire, and it's really important that actually how we can share elements and be more efficient. And I found how we work through that process is sort of starting to really take shape. The Kirklees ICB is where all the money comes into that supports all the providers into the system. So I will get the funds in and I will distribute them out through to the providers such as CHFT and Mid Yorkshire, etc., and to the local authority. What the Kirklees Healthcare Partnership is a group of organisations that form of how we will strategically work as a system across Kirklees to ensure that we provide the right care and services for the population of Kirklees. However, from a financial perspective for myself, I only report from an NHS organisation. So the West Yorkshire ICB is just made up of of NHS organisations. However, Kirklees is really different. It has Locala, we work really closely with the local authority, and a number of voluntary care sectors, which is part of the healthcare partnership. We have been working together across the system around delivery of financial sustainability, and this is party to every organisation. So we have a financial forum where each Director of Finance sits on there, including hospices and some of the voluntary care sector, because they can really bring a different perspective to things that we do. So the information I'm providing it does include the NHS organisations, and it also includes Locala and the local authority. Next slide. I can't see that, so I hope you lot can. So what I wanted to do is just reflect from 22-23, because it was an incredibly hard year. And I think, Yolanda, you mentioned that we've come out of COVID, and everybody thought COVID was hard, and we always anticipated the impact of that, and the services coming out of that would see a real challenge for us as we're going along. During that period of 2021, 22, we were put under a national framework. So it worked quite well, but it was a bit challenging. We like to make sure we do things right, but we had fixed things to try and reduce bureaucracy. But what we can see now is, as we've moved out of COVID, you can see, and you've all touched on it, that increased cost of inflation, staffing cost pressures, waiting list backlogs, and the impact of cost of living, which is impacting every organisation. So I won't go into too much detail, but you can always ask me questions. What I've tried to do is cover through what the position was as we ended up for last year. So the local authority, as you're aware, had a £27 million deficit. We achieved, as NHS organisation, a break-even position, so we spent exactly what we had. And Locala had a 1.8 million deficit position, and that was due to the impact of the pay award that came through really late. As part of the financial sustainability, we've created a number of groups. So we have created a financial strategy on how we will work and behave as a partnership, no cost shunting, sort of really understanding driving value throughout that. We've also created a joint recovery group, which has got the partners of Calderdale, ICB, ourselves, and we also would link with Wakefield and West Yorkshire. So what I've showed on the next slides is, I won't go into too much detail, is the financial plans for 23-24 for West Yorkshire ICS. So that will include Kirklees ICB and all the other ICB elements and all the providers that make up that. You can see we achieved a control total of a break-even position, but included in there was a system risk share, so we're now working together collectively of a £25 million value of how we would reduce costs moving forward. So, sorry, I've gone on to the slides and I've not told you, Yolanda. It's because I'm flicking. Can we go to next slide? 5.
All right, it's just not working on your screen.
You need to enable editing, I think.
There you go.
If you could just go up. Oh. It's on. Would it help if I connect? Oh, it's there now. Just go down to. Again. Yeah, thank you so much. Okay, so what I've shown is a West Yorkshire position, because obviously we are part of West Yorkshire and it's important, you can see the overarching position. However, what I've tried to show on this slide, could we go up one? That one. Oh dear. Is a Kirklees position. So we have a Kirklees Place position. So I will have all the different providers that feed into it. Because we're quite unique in Kirklees. We've got 2 acute footprints on our patch, which is really different to the coterminous areas of different places. So we've got the financial position that we've shown as Kirklees Place of the providers. And what I've shown also is the position at Q1, so month 3, which shows we have got a deviation in the ICB of £4.2 million, which is acknowledgement of the risk share that's come through. However, what we are committed to do is continue to improve that position and sort of reduce that back to a favourable break-even position. Could you just go on to the next slide? What I've tried to do is, for each place, is allow each area to provide the key risks and where they're at from a financial position. So Kirklees ICB, and Yolanda, you touched on some of the pressures that people have flagged as part of your previous conversation. So for Kirklees ICB, we had a surplus plan of 5.7. Currently, we've got a position of 1.5 surplus, so we have deviated. What we can see from a risk position is we can see increased activity in prescribing, inflationary pressures in premises due to utilities. I don't think anybody's immune to that pressure. And we've got obviously quite high efficiency targets as each organisation. What we are trying to do as an ICB is work systematically to try and lobby where we think some of those pressures are not of our sort of making in some respects, around inflation and the cost of drugs, for example, in prescribing, and looking at how we can mitigate. But also, the key focus of everything we do, and it'll probably go into the capacity and demand element that Vicky will talk around, is around transforming services. We can reduce and put efficiency targets in each of the organisation, but the long-term strategy is around transforming services, put my teeth in, but making sure the long-term sustainability, it's like a two-prong in-year and long-term strategy, which is what the financial strategy is of what we talk about. Shall I pause?
Yeah, I think the webcast have lost the slides.
Yes, we seem to have some technical issues at the moment.
Gives me a drink.
Yeah, sorry for that. Would you like to
Please
continue?
don't worry, it's fine. It gives me a chance to have a drink. So what I'm probably do is probably cover the trusts off in one fell swoop, because they're all highlighting financial difficulties. But if you look at the narrative I've put here, is they're usually in the same place: bed pressures, length of stay, strike costs, licensing costs due to IT, pressures on delivering the efficiencies that are being asked, pay award. It's a very long list of similar issues. But what I can give the assurance on, and you may want to sort of talk in more detail later, is around that commitment to join working, of how do we make those efficiencies together. So I'll skip over the, so I'll move to Locala. I think Locala, oh sorry. It's catching them. So Locala is in a similar position as a social enterprise. They have their own challenges, but they're basically the same. Pay award issues. As an organisation, they were not funded for the national pay award the last year, but we are lobbying NHS England around that, and there's lots of communication going on. But what we're doing is looking at how we can manage vacancies, not reliant on agency to cover pressures, but also looking at how we sort of do things together once rather than paying, because I think that's the key. Finances are a limited factor, but so are staff, so it's really important to recognise that. And we are also looking at because we are in financial challenge, there is additional controls that we're putting in place around how we spend things, so extra governance, and that's happening in all the NHS and local organisation. So I'll pop to local authority, but it could be that you want to come in here, but what they're saying is there is high delivery of targets, same issues with the inflation, cost of pressure of pay awards, energy waste controls. You know, it's just impacting us all, but they are mitigating that by spending controls like we all are, and identifying additional saving programmes. Do you want to add anything to that?
Thanks, Alison. I think just to say that it's no surprise that the council's facing significant financial pressures. That's no surprise to anybody in the room. We are all over the national press at the moment, so there are significant challenges, as everybody is aware. But we are, like Alison says, putting as much spending controls in place as we possibly can. We certainly are working very closely with our Section 151 officer and other strategic directors who are putting those controls in across the council. But it is really, really challenging. The deficit is in the region of 47 million. But we are trying to make sure that in-year savings are brought forward, that we're looking at all the assets that the council owns and bringing those saving proposals forward so that we can mitigate cost in year. If we do that successfully, that means that we can spread the load over a number of years, over the next 3 years. So it is a blip for a couple of years, but if we do the financial controls that are in place, we are hopeful that we don't have to issue a 114 notice. So that's the position. Thank you.
Yes, thank you.
So just, if you could just go on to my last page, because I think for me this is a crucial element of everything that we do. It is really challenging financially. I don't think any system is not facing that. If you look across the whole of the country, we're all in similar positions. But for me, it's important as part of the long-term strategy of financial sustainability is we don't just look in year and make decisions that don't impact the longer term. It's around understanding whatever decisions we make that they are considered from a health quality impact. So everything we do is quality impact assessed. I just really want to make sure that people recognise that. So for me, as part of our financial strategy, which we've all signed up to, is a focus to drive health inequalities out and understand the needs of the population, because I think if we don't do that, we just probably would just be round in a circle in a couple of years' time. The needs of the population have changed from 2 years ago, and it's important to recognise that. We are working as a partnership, and it's hard, but it's really enjoyable actually working together. There's a real steer of no cost shunting, working together, sharing resources. So around reducing running costs that are the same, how can we do things different, and duplication. We're all really focusing on an organisation, place and a system. So I attend lots of recovery meetings. I've got one in my own local organisation. I work with my partners, but I also work over West Yorkshire of how we can do things differently. Again, tied to controls on expenditure, but again, I just really want to labour the point around transformation of services and sharing of resources, and that one estate, because that's one thing that we've got a lot of estates and we don't maximise that. Again, I must send a lot of emails to NHS England lobbying. So, and also, it's really important that we drive value in everything that we do, because we can always be more efficient. So I'll just leave it there. Thank you.
Okay, so the next bit sort of comes to us. If you can move on to slide 11, please, Yolanda. We're on 11, sorry. Let me
Chair,
get it right.
I think
Yes,
we're
slide
just moving
11.
on to item 9 now in the agenda pack on capacity and demand.
Yeah, because it's the same. Yeah, same. So slide 11 on your slide pack. Next one, please. Yeah. So what I've done on this slide is I've just tried to remind members of the actual questions that you posed to us. As I said earlier in the introduction, the questions that you posed were a refresh on what were presented, I think it was October, November time last year. The one difference that you specifically asked for this time was about the children requiring dental extractions in hospital. So we have included that data in, and what you will see in the presentation is we've got more up-to-date information than was in your original slide pack. And then there were a number of golden threads that were running through the questions that you posed for us. So that was specifically about workforce recruitment, retention, the impact of COVID and health inequalities that we picked up on. So the approach that we've taken to pulling these responses together is that we've done this as a partnership response, worked with all the partners that are here today, including Mid-Yorks, who obviously not here, so that's both our acute trusts, Kirklees Primary Care Trust, Adult Social Services and Locala Community. And what we also included in the pack was an update on the community diagnostic centres, but we recognise that you had quite a detailed presentation at the end of last year on that one as well. So if we move on, Jackie's just arrived. She'll be in time to do her a little bit. So if I move on and pass over to Johnny, Johnny can pick up for the CHFT element.
Thanks, Vicky. So in the slide pack, you've just really got some key headlines, but I'm more than happy to take questions at the end. So overall, our waiting list is in line with our recovery trajectories. The waiting list size, actually the dates are wrong in this. It should be our waiting list size in July 23 is the same as around about the same as it was in October 23. So we've been able to reduce our longest waiting patients, but not increase our overall waiting list size. That said, we do have some specialties that are particularly challenged, and this is largely linked to workforce challenges. So ENT and gynecology particularly have seen waiting list size increases over the last 9 months. That said, we are reducing down our volume of patients waiting significant periods of time. So we now have nobody waiting over 65 weeks, which was the initial challenge put by NHS England, to have nobody waiting over 65 weeks by the end of this financial year. And then in terms of the additional challenge that NHS England imposed about not having anybody waiting over 52 weeks, and that's what we've signed up to as West Yorkshire, we're also ahead of target on that. And as of July 23, we had 24 patients waiting. Again, the majority of those being in that challenge specialty of ENT, of which we have a number of internal actions on. In terms of diagnostic performance, we're on track with the exception of echo and neurophysiology. So if you remove those two specialties, our diagnostic performance is in the high 90s in terms of percentage. But again, those two specialties are challenged due to workforce issues, national workforce issues. And in particular, there is a particular challenge around increasing rates of pay nationally, which poses us some problems locally. Just in relation to surgical dental extractions, so this service is provided by Locala, but we use our theatres, so we support with this work, and we've currently got 12 children waiting for extractions on our waiting list. And are you okay, Jackie, to take over? Yeah.
Yeah, thank you. Who's driving the... Yeah, thank you. I know who to look at, that's all. I know who to nod at. Thank you. So yeah, apologies for being late. A meeting overran over at the hospital. So I'm here on behalf of the Q for Mid Yorkshire Hospital, Teaching Trust now. So I'm Jackie Tatterton, Head of Transformation and Continuous Improvement. And we have a new Q that just joined us this week officially. So Chris Evans unfortunately has a clash because he has a lot of meetings in his first week. So he wasn't able to come, but he did want to pass on his apologies. And obviously, once that these are scheduled in his diary, he knows when they are. He'll make sure that he's here for the next one. So he asked me to pass on his apologies. So just in terms of the slides, there's quite a lot of information in here. So a few of them I think will just be kind of skipping through. So yes. Okay. Perfect. Thank you. So in terms of the key messages, so we have had an increase in our total waiting list over the period of time that's reported in here. We also have had a slight increase in our follow-up backlogs, but we haven't seen a big increase in our follow-up backlogs as well. So we've been trying to make sure that any work that we do is targeted on both of the waiting lists, so that we're not fixing one but then having an issue with the other. So we're trying to make sure that the work that we're doing is aligned, but we have had an increase. Our cancer demand numbers are high. So we have over 3,000 patients that come through a month requiring a cancer referral. So we've got significant numbers of those. And obviously, as the same as everybody else, the industrial action has obviously affected the waiting list. In terms of 78 weeks, we've got 14 non-admitted patients and 34 admitted patients with just one diagnostic breach for a complex patient. So our diagnostic position is particularly good at the Trust. And a lot of that is because of the work that we do with primary care to kind of arrange diagnostics up front for things. So we've got a reasonably good position on diagnostics. 65-week position, we've got 185 patients that are away from trajectory, and similarly to other areas, ENT makes up a large proportion of those. As I say, diagnostic performance is good, and we have 119 paediatric patients waiting for surgical dental extraction. And again, we're working with our dentist colleagues to try and look at what patients are sent through for dental referrals to make sure that we are seeing the appropriate patients at the hospital and we're not seeing those patients that could be managed outside, so that will help with that. So I think that's everything from us. Thank you.
Thank you. I've just got one question. Mention was made of echo. I know what ENT is, but I don't know what echo is. Could you please enlighten me?
Sure. It's a diagnostic procedure. It's echocardiogram scans. So it's undertaken by physiologists that they undertake quite a period of training. And there's a national shortage of those people that can do the scans. But essentially, it's checking the blood vessels of your heart and around your heart.
Thank you. It can be sometimes confusing when the jargon creeps in. Thank you. I think we're essentially running two items together here, items 8 and 9, because there's so much overlap between them. So I think if our colleagues are all right with that, can we carry on with the presentations and then take it as a bundle at the end of that, please?
Absolutely, thank you. So, Catherine Wormstone, Director of Primary Care, if you wouldn't mind moving the slides on, thank you. So again, there's just a few slides in here on the screen, but more detail in your pack. And again, I'm very happy to take questions. And we've very much updated some of the information that we've spoken to panel about previously. And primarily with a focus around access to primary care. So we know that this remains a really high priority for obviously the government and a lot of very extensive media coverage, but obviously for our patients as well. So I think when we spoke to you last year, we were just getting ready to mobilise enhanced access in October. So pleased to say that's been successfully mobilised and we're delivering consistent hours outside of normal general practice hours, so evenings and weekends. And then very recently we've started to offer a few appointments, so we're just trialling this at the moment on Sundays. So that wasn't in the government's original spec, but what we have worked out is that particularly in times when we've had sort of wider system pressures or strike action, that actually that extra capacity on a Sunday does help. So we'll be continuing to trial that through the winter. In terms of demand, it's really high, and there's a slide following that shows some of that on a graph, but not only have we recovered our position pre-COVID, but we're way outstripping some of that now. Workforce challenges, as we've reported through other providers, remain really difficult, and often for practices who are quite small teams, that has a severe impact if they're struggling to recruit or retain their staff. But the additional roles reimbursement scheme has got really good traction now in Kirklees, and I think we're at 192 full-time equivalents, which is great news. It's really supporting some of the workload in primary care, but puts an inevitable pressure on the premises. So we solve one problem and then have to work through some others. A lot of the emphasis around access is still working through a model of digital first. Obviously, that got a lot of attention in the early days of COVID, and people were very used to having video and telephone consultations, but now what we're trying to work through is that getting that right balance for patients, because not everybody wants a digital conversation, but for some people it remains really convenient. So we are trying to make sure that there are no groups of our population that are digitally excluded. And right now we're making preparations for winter, and a big part of that is the winter vaccinations. So COVID and flu vaccinations will be high on the priority list and will be something that primary care are helping to deliver. So if you wouldn't mind moving on to the next slide, please. So this is just the graph that I mentioned, so the blue line that you can just see at the start of these first few months of this year, way higher than previous years. So again, we often have the conception that general practice isn't busy, but you know, some of the data that's drawn directly from our general practice clinical systems is showing that it is really, really busy, and it's very pressured. The next one's interesting, if you wouldn't mind moving on. This is about numbers of appointments where patients have not attended. I know this is a common problem for health services, but when you start to look at the numbers, sort of 8,000, you know, it's high. That's a lot of wasted capacity, and we really want to work with our PCNs to try and take measures to reduce that, and obviously educate patients in the importance of attending for appointments. Next slide, please. So just a little bit around winter. So our recent guidance landed in July, and it's really focusing on the primary care access recovery plan, which I think we're coming to talk to you about at the next panel. So we'll go into lots more detail then, but there is an obvious focus there on the sort of retaining and maximising the use of those additional roles, maximising uptake for flu and COVID vaccinations. The government made a commitment to offer an extra 50 million appointments per year, and Kirklees is, you could see from the graph, we're actually doing really well on that. I think we're about 6% over the trajectory at the moment. So again, it feels like we're playing a really strong part in that recovery. We are looking at some of the high impact interventions that worked really well last year, one of those being acute respiratory infection hubs, and they were set up very reactively last year in response to some of the presentations that we were seeing, particularly in children, but they worked really well for a short time. So again, I think we're well advanced in plans to remobilise those. Looking at the capacity of multidisciplinary teams, particularly over that Christmas and New Year period where we know we get bottlenecks, trying to work really hard on that interface between primary and secondary care. Often it's the communication and the relationships that need a little bit of work, and I think because everybody's really pressured, sometimes that, you know, that's the bit can sometimes feel a little bit frazzled, so we're putting a lot of effort into that. And then, as I mentioned, putting extra capacity in on bank holidays and Sundays over and above the national requirements. So I think that's all I've got in my summary slides, but again, be happy to take questions on any of the other bits in the pack. Thank you.
Yes, thank you. Michelle Croft.
Wait, I thought you might have a question. Thanks, Chair. So in terms of local authority and demand and capacity, there's a continued increase for demand in community and for discharge support. That's been considerably challenging given the pressures that hospitals are facing at the current time with strikes and various things. However, we are managing to discharge people still in a timely manner. In terms of context of recruitment and retention challenges across the sector, I think everybody's alluded to the fact that that's still a challenge for us. However, we are seeing that people are starting to come back to social care. We've seen a slight increase in people wanting to take up posts in social care. Be it small, people seem to be wanting to come back, so that's a positive sort of message for the sector. I think we are seeing a high level of complexity, and that's evident through the increases of care packages. I think we alluded to that again earlier around the complexity of people being discharged from hospital, but also in the community. We've seen an increase in complexity in hours that's gone from 11.5 hours from 2020 to 13.5 hours this year, and I think people are, you know, that is evident in the pack as well. There's more detail that sits under that about why that is. We are continuing with our discharge to assess approach. That's been sustained. Home First through enablement and our intensive intermediate care resources ensure decisions about long-term needs are made following rehab and recovery in the right setting. I think the overarching principle that we're all adopting is that discharging people home with the right support, and that is shown in the increase in our home care hours. In terms of market sufficiency, we have a number of discharge to assess beds across the sector. We've got local levy funding agreed. We continue to work with our partners on bed modelling and making best use of resources to enable that, but with an overarching plan to reduce reliance on beds. We've agreed weekly set of rates for our D2A beds, which takes into account a higher turnover of these beds and additional work that involved by providers in facilitating speedier assessments and paperwork. And we continue to do this in consultation with our independent sector providers. I think also a part of that, we continue to fund Kirklees Care Association. I think some panel members met the Care Association last year when we did a full session on adult social care and the benefits that we're seeing from working with those providers in the social care market are paying dividends. We're particularly seeing increases in digital funding, where digital care records are being implemented across provider provision, which is proving that we are doing less in terms of paperwork and more care, frontline care. I think what we've also got with our Care Association is they are representing themselves on key stakeholder partnership meetings and providing workforce development. They're a key partner across all strategic meetings and work collectively with ourselves and our ICB colleagues. Care home placements, as you can see, are at pre-pandemic levels with significant increase in domiciliary care. You'll see from the pack and also the information presented that we've seen a significant increase in domiciliary care hours. It's gone from 9,000 hours in 2020 to 20,000 hours this year. But just to sort of reiterate that we've got no waiting list in Kirklees for home care. We are the envy of our regional colleagues that we've got no home, we've got no one waiting for home care. And last year we completed our fair cost of care exercise and submitted our market sustainability plans to Department of Health and Social Care, and we continue to work hard with providers to work closer with them to make sure that we understand capacity and demand across the system. Thank you. Any questions after that?
Okay, thank you. So in terms of local community waiting lists, you will have heard from colleagues when they last came to present about the work that we'd started to really review and get underneath what was happening with our waiting lists and where our clinical services needed some support with getting back on track. And that's continued. We had a challenging winter, as did the system. Which led to an increase in waiting times over the summer. But over the last 3 months, we've seen the positive impact of the work we've been doing, and waiting lists are starting to come down. We've had some pretty good progress in areas like musculoskeletal services and some of the other services that we deliver in the community that have targets around waiting for no more than 18 weeks, and we're just about on track with all of those services. We also have targets around 4 and 6 weeks from referral to first appointment, so that we're making good progress there as well, and we ensure that everybody has a full clinical triage and a review before they go on to any waiting list to make sure that they are safe to wait, and everybody gets information about what's normal for them, how they can stay safe, and when to come back to our services and escalate any areas of concern. And that just makes sure that we've got confidence that they know what to do if their circumstances change. So all of the teams have a tool in place now where they can adjust the amount of clinic times that they've got to particularly target around health inequalities, because we know that people who are already suffering from health inequalities are greatly impacted by waiting longer for care. And we've got a particular focus on children. You've heard a little bit about dentistry, but in terms of children overall, we know that having a good start in life, and particularly getting early treatment, is really important. But that is one of our challenging areas, because they tend to be clinicians with highly specialised skills. There aren't many of them around. So what we're doing alongside this is working out where we can support our own colleagues to get extra skills and competencies to enable them to work across a broader group. Another example is in terms of learning disabilities. So we're working in dentistry and the other areas of our services where we support people with learning disabilities to make sure that our clinicians on the ground have got a good overview of how to work effectively with people with learning disabilities. And the last point there is just about how we're continuing to work with partners around things like discharging effectively into the community with Michelle's teams, and that continues to ensure that we've got good support when people do come home after a spell in hospital.
Thank you for that. Excuse me. Quite a lot of information. Can we just hang on just one moment? I will invite you all to be questioned by the panel. Councillor Khan is also here today, and in particular, I believe we should talk about changes to services in North Kirklees for people with a learning disability, including capital investment. Or anything else you would like to say, Councillor Khan?
Thank you, Councillor Armour. I believe Scrutiny were fully briefed last March, and we're happy to set up another informal briefing to go over that particular area, if required.
Yes, thank you. That would be very, very useful. Thank you. Is there anything else you wish to discuss with us? Is there anything else you wish to discuss with us? We'll fit that in on the work programme.
No, unless you have any questions.
Not personally, but if you'd like to just wait a moment, because I'll now invite the panel to give any questions. I know you've had a lot of information given to you, but do we have questions for any of the people who presented? Anybody wish to start on that? If Councillor Smays would like to...
I think there's a chair over there if you wanted to sit up there, and then if you just turn your microphone round, it'll...
well,
I never could observe a meeting quietly. I'll start off with a question. So I think Mid Yorkshire identified that you had quite a few cancer referrals coming through, and I wondered if you were doing any assessments of the types of cancer that were most prevalent, to see whether there is any work within the community that is needed to help with screening, etc., whether there's any trends. And I was also wanting to know about the dentistry and the impacts of the long times that people are waiting for dentistry, because several weeks is a long time when you're in pain, isn't it, for treatment? Thank you.
Just borrow the mic. Thank you. So I suppose in terms of the cancer referrals, we have done some analysis on where they all originate from and the areas that have the greatest volume. Dermatology is one that has a very high volume of patients that come in a 2-week wait capacity, and we have a small conversion rate for patients that do end up converting and unfortunately having cancer. So we have looked at different ways of managing those patients. So we've just in the last couple of weeks implemented a service where our primary care colleagues can contact secondary care colleagues directly through the patient record, and they can provide them with images of the lesion, which are then reviewed within a couple of days, and then the consultant and the primary care colleague can then determine the best route for the patient. And what we're trying to do is make sure that those patients with a suspected cancer lesion end up in the 2-week wait clinics, and other patients are managed accordingly. So we're trying to kind of help support patients, and we've seen some really positive sort of it's very early days for it, but we've seen some really positive signs in terms of the number of patients that have come through that have been managed outside of the hospital or have been managed in a routine or an urgent capacity, which is then hopefully starting to free up some capacity to see the 2-week waits, because we do have a long wait for those patients. So we're trying to do kind of targeted work to try and support it, but as you can imagine, there is no quick fix, so it's spending the time to look at each one to try and work out what the solution is. And then the second question, I'll have to take that away if that's okay, because it's not an area that I work with, so I wouldn't be able to answer that one. So is that okay if I take that one away? Okay.
In terms of community specialist dental, which is the element that Locala delivers, which tends to be children, young people, adults and people with learning disabilities, who often it's around dental phobia. But just in terms of your question about pain, yeah, of course we don't want to see anybody in pain any longer than necessary. So there's 2 things that we do around that. One is that pain and pain markers are part of our initial assessment. And one of the triggers that would tell people to come back to us and escalate if their circumstances changed. But the main way we're working through that and working with our community dental partners is about making sure that they're only referring people who have got genuine phobias, and often it's if they don't have time to work with somebody to kind of go through, to settle them down, etc. So some of it is just kind of working backwards and forwards between ourselves and our community dental partners about how we can support people differently. And some of it is about that education around things like learning disabilities, working more effectively with people who are frightened of their dentist, shall we say.
I think you had particularly long wait time for paediatric dentistry as well, didn't you? And I think that would be helpful to have more information as to what steps you're putting in place as a trust to reduce those times that people are waiting for dentistry appointments and treatment. Thank you.
Please.
It's just to come back in on the point about the cancer question that you asked, and specifically about community. So one of the pieces, across the whole patch, there's a lot of work ongoing about early detection, early screening, to try and help at the front end rather than wait until people get to the hospital. And we've got some really good results starting to come through, and you will have seen on the media they've talked about the lung health programme. So across North Kirklees specifically, that's a programme that we've been involved in as part of the pilot work for NHS England. And nationally, we've performed better than anywhere else in the country. We've had a much higher success rate in attracting people into the screening programme, but also in the people that we're detecting early, not only with early signs of cancer, but other conditions that are being picked up through the lung screening. And hot off the press, is that we have been successful in gaining support to roll that out further across Kirklees and potentially into Calderdale as well. So there's work we've got to do around the implementation, but NHS England have come back to us today and said they want us to lead that on behalf of this patch. So that work and the community work is starting to have some real positive benefits. I do think it would be worth possibly later in the year, and when I say later, I mean towards the back end, doing a specific focus on cancer, because there are some significant changes coming through that I think will raise anxieties, but that we'll be able to show all the evidence of the work that we've done as well that will help mitigate some of that.
Thank you.
Yeah, I just wanted to ask a question around the waiting list. I think it was yourself that covered it. And in particular, in terms of the joint working between primary care and secondary care, what sort of, is there any initiatives or programme of work that the ICB is doing to try and facilitate better use of that joint working, particularly with winter coming up and the winter pressures, to try and alleviate some of that capacity in secondary care?
Thanks. So it's a good question. So we've been working, coming through the COVID phase, we started working very closely with primary care through what we call the elective care recovery group. And so our primary care colleagues are integral and involved in those conversations about the clinical pathways. So one of the things that had the biggest impact is we set up and really focused on our advice and guidance lines. So primary care being able to essentially access opinions from our secondary care clinicians sending a referral through. So that's meant that we've been able to manage individuals in the population that don't necessarily need a clinical appointment in the hospital, but need to be managed effectively in the community. And that's something that the GPs have really supported and are really keen on. We monitor those rates on an ongoing basis, and occasionally we have one specialty that drops off, and then we have some focused work on that to bring it up. So that's been really helpful because that's reduced the number of patients coming in at the front end onto those clinical pathways in secondary care. Over and above that, we've done a lot of work on our operating and making sure we're as efficient as possible. So our position is kind of a collection of lots of different actions, but we're now in a place where we're ahead of trajectory. There is some risk, particularly around the strikes. So the consultant strikes in particular having a big impact on the volume of work that we can do. So we need to keep monitoring that and try and work around that. But that has had some impact, but we're still ahead of trajectory currently. And the only other thing I would bring in is at the end of the patients' pathways, we're looking and again working with primary care closely on how we can manage patients to discharge them with support back into the community to prevent them having to come back for multiple follow-ups with our consultants in secondary care, but also doing it in a way that doesn't land lots of additional work with primary care, because clearly, as you can see, the volumes through primary care have gone up as well. So I think, I can't remember who mentioned it, but it's kind of doing the right thing once rather than having repeated appointments.
Yeah, no, that makes sense. Sorry.
Yeah, just to add to that, because you asked about incentives as well, because obviously we work across the whole patch, so we've been doing equivalent work with colleagues in Mid-Yorkshire, and we do have an incentive scheme to encourage our general practice colleagues to work in that way, because it is quite a little bit more work that they have to do to sort of make sure that patients optimised and had all the tests that they need to have before they get into that hospital setting. And it is again something that we keep a close eye on and monitor how well that's going, and hope to be able to sort of expand that with other pathways as things sort of come online and become a little bit more manageable across all of the different parties that are involved.
Yeah, no, thank you. I do actually think that initiatives like that are really useful, not just from an efficiency point of view, but from a patient experience perspective as well. So where you can deliver that care closer to home reduces their time that for them to receive treatment, but also that whole experience.
Hi, just to follow on from that, please. With more community care and avoiding going into secondary care and the early discharge, is this putting a reasonable pressure on GP surgeries and primary care services? I mean, people already report back that they struggle to get appointments and things. How are you managing that to this extra capacity into the primary care sector?
Is that in relation to patients that have come in acutely unwell and trying to discharge them back home, do you mean?
Well, both what you've just been talking about, you know, the idea of avoiding going into secondary care and people coming out early. It seems like it's putting a lot of extra pressure onto that primary care. I mean, it's great. It's a good idea to keep people out of that secondary system, but is there the capacity? Can it be done, and how are you managing that?
So I think there's a number of bits that we can pick up on that. So some of the schemes that are recognised across both trusts is that there's an element of patient-initiated follow-up. So that's about the patients deciding for themselves when they need a follow-up outpatient appointment. So it's about the education that goes into that from the trust at that point of discharge. We do lots of ongoing work then with primary care about supporting them in managing the patients that insist on still turning up at the GP practice and how they can get them back in. But then there's other schemes that are ongoing across our collective system of services. So, for example, the development of virtual ward, which is about, trying to keep those people who don't need to go into hospital out of hospital, but putting that whole wraparound consultant-led service into the community. But that is also facilitating earlier discharges for people. So those people that have been in because they needed that period of care in hospital, bringing them out earlier, but they've still got the consultant oversight and care with a community team delivering that into their own homes. And the benefits of doing that for us is that we know that the longer somebody stays in hospital, the more they decompensate, the more care that they then need at the other end. So the sooner we can get them out and back into their own environment, say it's more comfortable for people, B, we've got that wraparound service and we can do the assessments in their own environments. And then you're supporting them to maintain that independence and stay at home, even sometimes with the additional capacity that comes from our social care colleagues. And that's where the system's working collectively together to do that.
So,
I just probably want to add from a primary care perspective, because it's still a lot of work for primary care and we can't take away from that, but we are trying to do that. And I think what nationally they've recognised, it's better to be treated at home and in the community. And Catherine's mentioned around the hours roles and the number of whole-time equivalents have been, there's been so much investment in that primary care function to try and alleviate some of the pressures on GPs to do other things. So there's a lot of pharmacists, mental health advisors. I can't list all the roles, but what I think the system's hoping that those will alleviate the pressure on primary care GPs to undertake the needs to actually see the patients that should be there when they need to be. So I think there's loads of little jigsaws to this, I think, that actually is trying to marry together. So the acute focus, but also from a system, how do we support primary care? Because Catherine and I sort of work quite closely with the primary care colleagues, and what we can see is we've worked close with them to develop services that are best being done in their site, because people can't travel and things like that. So we're trying to have that holistic view over everything.
Yeah, thank you.
Our primary care providers feeling that this cutting of demand by getting people straight in the community, less need from that because they get better quicker, and the support that they're getting from other services like the pharmacy you mentioned, mental health advisors, and all the other things. Is primary care feeling that that's working for them, or is it still a big extra burden?
I think it varies, and it varies at different times in the year. You could probably see through that graph that there are peaks and troughs. And I think, as Alison's mentioned, some of the additional roles, particularly the number of clinical pharmacists, we've got lots of those now across Kirklees, and general practice can readily identify workload that they can support with to free up other clinical time. But I think it would be fair to say that they are feeling the pressure. I think there probably isn't a sector across the NHS at the moment that isn't. So at times that sort of felt more acutely, particularly as, like we said, we're coming to winter. So I think that's where it becomes really important how well we work together and how we share resources and communicate across what has sometimes been some of those historical organisational boundaries. And I think trying to work in a much more of an at-scale way within primary care networks. Obviously we've done updates to the panel previously about that, and sharing resource across different GP practices is something that there's probably still a way to go on that journey, and trying to really deliver the services that can be delivered at scale. So sometimes if they've lost a nurse who's got training in X, Y or Z, that they start to share that more readily than perhaps they would have done in the past. So I think there's lots of ways we can support them to transform services further. But yeah, it is still pressured at times.
But are you feeling confident that it's still the right way forward, and that there is the capacity in the primary care area to do this, and you're getting the support you need, basically?
Yeah, I think we are still confident. I think Kirklees, when we've talked about the hours roles, I think there are 17 in total that they can recruit from. We've recruited to 16 of them. And as we've mentioned, some of the full-time equivalent numbers and the massive investment that's gone into that. And that's not necessarily the case in all areas. I know other areas haven't been as successful in recruiting to some of those roles. So, the fact that we can build that capacity and build it quite quickly is absolutely, part of that assurance that we've got to build all of that sort of skill mixing across teams. I think there's probably quite a bit we need to do in terms of educating patients, that there are a whole range of roles there now. Often, some people will still want to see a GP and they'll not be happy until they've seen a GP. So we know that alongside all of this work in building capacity, we've got some work to do to to try and, you know, advise patients, signpost patients, lots of care navigators now in general practice to try and help patients get to the right role at the right time. But yeah, I think we've come a long way. There's further still that we can go, but yeah, got a good degree of confidence on that.
Yes, thank you for that. I'm not certain who was first, so I'll go for Habibam, please.
Thank you, Councillor Armour. My question is around early discharge from hospitals. So where you send patients home, if the adequate adaptations are not there, that is putting a lot of strain on families and on certain services. So how are you working together with some of those services to alleviate some of those pressures? Because particularly as a councillor, we're getting more and more demand from patients, elderly patients that are being referred back as part of early care, and they're at that situation where they really need that support urgently, but because of the demand already on adult health and social care, we're not able to meet that, and we've got a waiting list of like 6-8 months. So how are we going to alleviate some of that in terms of your partnership working?
So I think there's a number of partners can come in on this, and there's different elements to the discharge element. So there's individuals that come out and go into what we call discharge to assess beds, the D2A beds or reablement beds, and they're short-term placements, whether the reablement is in a care home for 6 weeks or they have it in their own home. And with that, there is a defined sort of set of criteria and package that people will have, but part of that is also formulating an assessment to the longer term. So what are the longer term needs, which might be additional pieces of equipment, and there's a difference between the equipment that people have in their own home and adaptations that are needed to the home to help people manage. So we have to be mindful of that. And again, it's criteria led, so it's based on need, not on want, so what somebody might want. The other bit that we do though is our services work really closely with all our community equipment services, our wheelchair services. So we have a whole catalogue of equipment that if we say it's core types of equipment, so it's things that we would routinely think we need to give either following an operation. So if somebody's had a hip replacement, we have a set of equipment that people will get and will take from hospital with them, which will include things like walking frames, toilet raisers to help them. And they'll have that short term as they get their reablement and start to mobilise and get back to as independent as possible. But equally then on top of that, we have access to specialist mattresses, specialist beds, showering, bathing facilities, but it's all based on the assessment of those individuals. We're lucky for Kirklees compared again to some of our neighbouring placements that our equipment store we've commissioned or procured jointly with the local authorities, so we have a single provider that does it. We have very clear standards of delivery time, so people will get their equipment within 24 hours or not quicker if needed. Everybody will get theirs within 48 hours, so that's the standard that we have. And if there is somebody who's got what we deem exceptional needs, so if the hospital are wanting to discharge somebody and they say, we can get the ambulance now, we will pay an increased fee to allow that. We do have a budget to allow us to do that delivery, so people will get those basic levels of equipment. Like I say, if it's really specialist, sometimes people do have to wait longer. And that can be for a number of reasons. One, because it's specialist and we've got to buy it in. And other times it's because it's bespoke and it has to be made to their needs. So it's the assessment and the making of that equipment. And again, that can be a range of equipment. So it ranges from bespoke wheelchairs, but to specialist beds and turning aids that we've got. But a lot of what we see is what goes out 80% of the time we have as our core equipment now, and we do quick turnarounds to get it back, and we hold amnesties for people to be able to get that equipment back to us, so that at least we can get it back.
Thank you. Kim, you've been waiting a long time.
Oh, thank you. Thanks. I've got 3 questions actually. Is that okay? They're kind of similar themes. The first one is around the long waits, and I guess from a patient perspective, if I've been on a waiting list for over a year, and waiting times and waiting lengths are different and very subjective, but as a patient, how would I know that you've not lost my referral or you've just forgotten about me? How would you know that I'm still going to get what I need? And how do you manage my concerns around or any kind of deterioration of my condition, any worries that I might have around that? I think that's quite an issue that I hear round and about. The other thing is the DNA rate. I'm interested to see that that's actually a challenge at the moment and has increased. Are there any particular themes around that, and what kind of actions, what work is going on, because they're valuable, aren't they? Really valuable appointments that are lost, and it's capacity that's lost. So I'm interested particularly to know if there's any themes around that. And the last thing is just about the virtual ward. What speciality is that, and are there any plans to kind of roll it out, and how's that going? Because that's quite a big thing at the moment, isn't it, I think, in healthcare. And those are my three.
No, that's fine, that's great. So I think if we ask both Jackie and Johnny to respond to your first question about the long waits, the specific information we had on the screen about DNAs was primary care. So if we bring Catherine in then, and then the others, if they want to. Perfect. And then the virtual ward, I think it's between Johnny and, well, it's everybody, it's all panels, because we do that as a total system.
So the long waiters on the waiting list. So we have a number of touch points with patients when they get to certain kind of wait times. Some of them are just a letter out just to say that they are still on the waiting list, and we'll get round to them as soon as possible. Most of them are signpost patients to other services, so waiting well services, so other areas that can kind of help them and kind of maintain and manage and support them whilst they're waiting. And we also have within the trust a patient record, so they have access to any of their referrals or any of the documentation from the hospital through that digital record. So again, any of the patients that are on that, which is about 120,000 of our patients that have access to that, they can see what's happening, so we can communicate to them a lot easier than we can in a traditional sending a letter out to patients. And although that all sounds really obvious, it hasn't always been done. So I think from the point of a patient being referred into secondary care, I think for a long time there wasn't really an acknowledgement that, yes, we've got you. So some of the things that sound really simple and really obvious, I think historically just haven't been done. So I think it is a really positive move that we've got all of that now, and we are understanding from a patient perspective what that feels like if you don't hear anything. And like you say, when it's 4 weeks, that's one thing. When it's a much longer period, then that just generates phone calls, visits to primary care. So the better we can communicate and proactively communicate, the better for everyone.
So what
really.
would the touch points be then in terms of time?
So we've got some specific guidance from NHS England in terms of 12 weeks, 17 weeks. So we kind of we go out and we contact the patients.
So people should get a letter.
And then we have and then we have various ones where we sort of dip in and send information out to them just to check that everything's okay.
That's great. Thank you.
And I'll could just say same, couldn't I? But it's very similar to what Jackie's just described. I think the only other thing I would mention is the validation processes that are in place. So we undertake administrative validation to check, because sometimes you have people on a waiting list, but they might be on multiple waiting lists, or they may have had private treatment because they don't want to wait any longer. So we go through a validation process to make sure that people still need their treatment and their appointments. And then we have clinical validation on top of that, where the clinicians will dip into the referral, check whether they think the patient may need to be brought forward because they're more urgent than the time frame that they're waiting, and we stratify the urgency of appointments or treatments to try and bring the most urgent people forward to be seen as quickly as possible. So it's kind of a mechanism behind the contacting as well.
Thanks.
Shall I come in on the DNA rates for just for primary care, because I think part of what I'll come back when we do the next update is the expectation that all of our primary care networks, all 9, have had to put a plan in place by the end of July on how they're going to improve access over the next 12 months. So that's part of the whole system approach to recovery and access, but specifically focusing on primary care. So we've actually shared quite a lot of that data back with individual practices for them to do that analysis and to look at where the themes might be, or where there are particular points in the week. So It's something all general practices
Yeah.
have tended to monitor, and often if you've been sat in a waiting room, you know, you might see
Yeah.
stats up on the wall. But I think what we've really noticed is, you know, where it's starting to creep up a little bit. Sometimes I know general practice will describe, you know, sometimes there's no logic to it. A patient will make an appointment in the morning and then DNA it 2 or 3 hours later. But actually some of the national guidance now that we're working within is sort of trying to make sure that patients have got an understanding of how their appointments are going to be dealt with or their request is going to be dealt with, and trying to sort of make sure that the arrangements for booking are not drifting on inevitably, because sometimes the longer the wait is between booking an appointment is sometimes where the DNA
I
is
think
creeping.
that was my question. Really.
Yeah.
I just wondered, could it be a possible scenario where people are struggling to get an appointment, they book one, and then
Exactly.
you know they've either gone to A&E or they've kind of recovered and
Yeah.
they're just
Potentially,
yeah.
and then I think there are more and more sort of digital solutions
Yeah,
coming
sure.
in, and again, you know, you might be receiving far more text messages from your practice than you might have
Like
done a few
appointment
years ago,
reminders.
and quite often now the systems will prompt and they'll send a reminder a couple of days before. So I think there's lots of little things that the practices can do, but we are just keeping an eye
Be
on that
interesting to see
overall picture,
what
just to see
effect the work has,
exactly
whether it reduces. Yeah, thank you. And,
Anything else, Second?
it was just about the virtual ward. Yeah, I was just interested what speciality was it, and
You go.
Yeah, I'm out of the loop in terms of current specialties, but we started off with respiratory.
Okay.
I don't know whether hospital colleagues have got more
Yeah, so
up-to-date
we've been
positions.
focusing recently on elderly patients because of the suitability for kind of,
yeah.
you know, for management at home, and obviously not bringing an elderly patient into hospital. And we've got really good relationships between our elderly consultants and the community teams as well. So in terms of signposting, they're quite good at signposting to each other because they worked together in sort of building that. So we're looking with the kind of community provision around demonstrating the benefit of that and looking at how we could expand it and what group of patients to look at next. And we have a specific cohort of patients that we call high-risk patients. So they're patients that have frequent hospital attendances, they tend to have long lengths of stay, they tend to be frail patients, and could we put services in place using virtual ward and urgent community response and all of the provision of all the things that we've got to create a service that supports those patients a bit more and again keeps them out of hospital. So it's trying to do things, I think, that target groups of patients and provide the right level of service for them rather than doing a one-size-fits-all piece of work. So that's...
I think what is worth just noting is that we developed our plans for virtual ward with social care colleagues across Calderdale, Kirklees and Wakefield. So we got both acute trust partners part of that process so we could develop a consistent model. And for Kirklees community and social care, that's really helpful because sometimes we can find that the approach is slightly different in Mid-Yorkshire compared with CHFT, but because we work together as a collective to develop it, it's meant that we've got consistent pathways there. So so people in North are getting consistent service with South.
Same.
Yeah.
Thank you. Thank you.
Right.
Can I just add, so just to put as well, I know at CHFT you're looking at heart failure as well from a virtual ward perspective, and I think it should be recognised that what's really good in Calderdale, Kirklees and Wakefield is a joint programme. So I look after virtual ward for West Yorkshire, and we've got probably the more virtual beds than any other place. You know, we've been really, really forward thinking about it. And virtual ward, what we're starting to look at now is that, and bring out sort of local care direct partners around the urgent care response team, because whilst you may have a IT solution for a number of patients, some of those patients are frail and elderly and can't use an iPad or an iPhone, and I speak from experience from my own parents. But what we're trying to do is work with our local care director of how we can do an out of hour. So you've got a service where you've got people that you can talk to out of hours and various other things. So it's growing and enhancing as we move forward. So it's just really important to recognise that it will morph into something a little bit more stronger and more specialties, and each specialty comes with unique asks. So it's quite a really exciting project, I think.
Thank you.
No.
Thank you. Is going back to the virtual ward, what is the capacity of it at this present moment in time with the specialities they have? And has there been any kind of audit for sort of patient satisfaction with the service as well? And has there again any work being done on how many people that is actually stopping being sort of admitted to hospital or readmitted on their discharge?
I think that's one we're going to have to come
So
back
I might,
to.
I don't have the high-end numbers, but I think, and I don't want to quote numbers because it'll get quoted that I've said a number, and as an accountant we don't like to say the wrong number. It's quite a high number, but each place will have a different value. It only started probably mid last year, so it took a lot of time to get going. It was a new project at the start of the year, and it's on a phased trajectory. So I think it's really early days to see how it's going, but it's been evaluated as we're going through as part of not only from a local perspective, but from a West Yorkshire, but regional, and we have got a meeting in September with all the system leaders to talk about how virtual ward moves forward in our patch. So another one where we might want to bring something about learning a virtual ward in future sort of dialogue, because it is one of those things that's a way forward, but it also needs, I mean, and Vicky talk about this, it needs to talk to other services. It can't be a standalone sort of service, so it might be interesting to bring of where we're at moving forward. Michelle wants to come in as well.
What I will do, sorry, what I was just going to say is what I will do is I'll get a brief pulled together and sent to your Landy that just gives you the current position and the capacity that we've currently got in and by which specialities. And just to reiterate what Alison said, we actually only went live for winter last year, so we agreed it was going to be the frailty and the respiratory for winter last year, so anything else that we've added, like the older people's, the heart failure, has been built in as we've gone along.
And just to add as well, just to add, the procurement of the IT solution has been done over West Yorkshire, and that's only just completed. So it's starting to take the momentum. So 6 months' time, it might look completely different.
Yep. Thank you.
And I think I was just going to add to that. I think because it's quite an exciting piece of work, it's probably something that you want to consider to come back on your work plan. Because I think at the time when we did the workshop around what you wanted to look at and what you wanted to see in scrutiny, that was sort of in the beginning. So I wonder if it's something that we come back later in the autumn so that you have got all that intelligence at your fingertips, really. I think it'd be really exciting for you to see the outcome of virtual ward, because it does touch on all of the organisations as well.
Thank you. Sorry, Bill, I've got another question, if I may.
Yes,
regarding the community diagnostic hubs, it's pleasing to see that they are starting to go, but is there no plans to have a spoke hub in Dewsbury or Batley area?
Pick that one up. Yeah, I think so. This is constantly evolving, to be perfectly honest. So the programme is going to be over a number of years. The current position that we're in is that, having done the estates review of suitable premises, we haven't identified anywhere in that side of the patch currently to be able to do it, because it's got to be able, any estate that we use has got to be able to take equipment of certain weight and sizes and things. So it is under constant review, and it will be reviewed ongoing as part of the urgent care modelling that we're doing and the walk-in centre reviews that we're doing on that side of the patch as well.
Thank you.
Am I okay just to add to that, because it also goes back to the point that Alison mentioned about us having commissioned extra services from general practice. So a lot of the services that are planned to be part of a community diagnostic centre are also services that we've commissioned, and we've just recently commissioned from a lot of our general practice, and that would cover the patch across North Kirklees as well as Huddersfield. So examples around phlebotomy, spirometry, ECGs, those kind of things. So we've already got good provision, and we've recently reviewed it. So it's not that patients will have to travel. Hopefully it's something that we're providing fairly close to patients' home as well.
Just a follow-on from that point, really. In terms of the vaccination plan, I think you mentioned it in your presentation about expanding out into shingles. I've sort of seen that firsthand because I think my parents were invited for it. And in my area that I represent, obviously a large elderly population, it will have an impact on those. How's that going to be rolled out? Will that be community-led? And following on from that, I suppose there's a number of other vaccinations like the pneumococcal vaccinations, which probably from the respiratory hubs. But what's going to be the impact financially on us as an organisation? Is it, without saying, is it worth it? But, we have to look at the value of expanding that cohort of patients that we deliver to in terms of...
So I think you've asked a number of different questions in one question there. Just on the vaccinations, there's actually a West Yorkshire meeting tomorrow, which is going to be looking at the rollout of the vaccination programme and what that will entail and the timescales, because I think there's been quite a bit of pushback, if I'm perfectly honest, about when it's been released, but also that people were already doing a great deal of work. So if you look at the work that's already started on flu, the fact that the government are saying it's going to start in October there's a bit of a mismatch. So we're doing all that work, but there is a regional meeting looking at that rollout programme, and especially about the allocation that the government have said is going to flow, because there are concerns that the allocation is not going to meet the need that we have. And I'll bring Catherine in because a lot of it will sit in primary care.
Yeah, so just I think there's quite a lot of promotional campaigns running across our TVs at the moment around the shingles changes. So from the 1st September, they're expanding some of the age ranges for those vaccinations, and hopefully to try and sort of alleviate some of the complications and the pressures further down the line. But I think it's, again, not unrealistic to realise all of that's happening around the same time. So, COVID, flu, shingles, and often the practices will use that as a way to do opportunistic checks on patients as well, sort of more holistic checks. So general practice will be delivering a lot of that, and they will be looking at the viability of making sure that they've got workforce mobilised to be able to do that, but also with some of the changes that are being made to the payment structures for some of those vaccines, that they'll be looking at that. And for us as commissioners, it'll be incumbent upon us to make sure that we do deliver that campaign, even if some practices say, actually, I can't manage the workforce at that point in time. We'll be working with our partners around the table to make sure potentially community pharmacy or partners in Locala can offer or plug some of the gaps if they do arise.
Yeah, no, that's good that you've got a contingency plan and a backup to deal with that workforce. But can I ask another question, Bill? It's slightly different. It's going back to, again, in one of the presentations, it's really good to see the sort of measures that are in place to improve efficiency and cost savings that you mentioned. And one of the points that was flagged was around lobbying national bodies. So I was just really interested to know what kind of lobbying you do as an organisation, and with who, and is it effective? And as a follow-on from that, really, I suppose, ask the question, as Kirklees councillors, and particularly, I suppose, the lead for health and social care, Councillor Khan, is there anything that we can do to support or facilitate that lobbying at a national level for you?
Alison goes first, then Rachel.
Yeah. I might cover it off. What we've discovered is we get a set allocation at the start of the year, and sometimes we don't get enough to fund it. So if I look for me, I'll use an example of IT solutions. So we've got to make everybody 365 compliant, and the cost of that is really, really high. So what we do is we flag up those risks, and I know it would be in trust, and I've got a big risk in my place. We have been working as a system and linking with our regional NHS teams, and then up to the national teams. Another one I've been looking at is asylum seekers. So the change of funding that's come through is different for this year. We got quite a lot of funding to support hotel accommodation and various things, and it's really an emotive subject at the moment. So I was on a call with NHS England, sort of working with colleagues across the country around how we can sort of lobby and push and understand the real cost of asylum seekers coming into our localities, because it is quite huge, and it's really important that we give them the care that they need, because some of these patients are really complex with complex healthcare needs. So that's another example. I've also been lobbying around capital funding, because at the moment there's a real shortage of capital funding. It's done on a formula basis, so we're really pushing around, especially for me because I look after primary care for West Yorkshire, around the capital estates in that area, because there's very limited funding. And we've talked about joining the dots, all those R's rules and all these things, we don't have enough estates for all these people that could save and do lots of work. So we're working with the sort of national team. Again, I've been in touch with the national colleagues, and my big boss at West Yorkshire has also been linking with other people, and we've got a meeting there in relation to the pay award for the NHS organisations. It was funded for NHS organisations last year. However, for social enterprises, they did not receive that funding. So Locala, along with all the social enterprises in the country, have put a letter together. We've been working with Rob Webster, who's the chair of, the sort of chief of West Yorkshire ICB. So there's all these things that we are doing. For me, I've got a real big pressure around premises, you know, inflation rises, because as soon as you're paying for those overhead kind of things, it removes money from patient care. So it's actually, how do we sort of really push? So any help would be very greatly appreciated, but just to know that we are trying to do as much as we can. There's some costs that we can try and manage, but there's some that are just come left field that you can't, but there is lots of work going on around the Locala issue.
Yes, thank you. When it comes to lobbying, we don't do politics at this panel. I appreciate your thoughts about.
Yeah, no, it's just interesting to know what sort of work that you are doing, because you sort of mentioned top line, but just have an understanding of those different organisations that you're dealing with.
I think it's also about the phrase lobbying. Yeah. So what is meant by lobbying in our terms, as opposed to what a community group or whatever might be doing a political, and some of the other things is obviously about raising the awareness. So one of the things that we know, and Alison sees regularly, is the new drugs come out, and they'll come out with a set of criteria for the patients, and actually suddenly the cost that's associated that we haven't got the money for, the money that's going to flow isn't, and actually is that more of a priority than something else we're going to do. So in the way of using lobbying, it's about getting it back up and saying, actually, yeah, it might be the right thing to do, but we're going to have to do it at a slower pace in Kirklees, because we've got other priorities that we've got to balance it. So it's that type of work. So it's not the political lobbying there.
Yeah. I might change my word from lobbying to challenging on what my husband would say is nagging up the chain, maybe.
Right, panel, are we happy enough now? Essentially, we've taken two items together, two agenda items. We've taken 8 and 9 together effectively, because it worked out that way. It just made more sense. So we're actually asked as a panel to consider the information and determine if any information or action is required. I think we've had a great deal of information. I'll leave that up to you as a panel. But anybody think we need more information?
I think it'd be nice to check in with the virtual wards, and also with the DNA information and plans coming in place only in July. It'd be nice to come back to those and see where they've got to, maybe further down the line when you've had a chance to put them into place, for me.
Yes, in fact, I've been discussing this with Yolanda, and we're going to find a space on the work programme to include that. And
the DNA.
With the joined up hospital services, it seems to fit in nicely with that. So we will be keeping a tab on that.
We can adjust.
Right, panel. Well, first thing I think is I need to thank all colleagues. It's been quite a great deal of information. Obviously, a lot of work's gone into it, and I thank you for that, and I really do appreciate it. And I'd like to give my thanks to the staff, your support staff, who obviously have been doing some of the research for you. But thank you very much, all of you. Right, panel, moving on. And what we have now is our work programme, which we routinely keep an eye on. And I personally don't think, there's nothing that I particularly want to. We are making a couple of changes, as I said, about virtual wards. What I do want, what I do want to suggest is that we look at the golden threads, because it does seem to me that hopefully COVID is past its peak, well past its peak. But as we've been hearing, so much hangs on financial pressures, on funding pressures, on economic circumstances. So what I'm asking is that we delete the COVID from the golden threads and replace it with a thread about economic pressures. I don't want to put extra threads in because they can get a bit tangled up then. So I'll be asking you as a panel to consider that. Before I do that, do we have anything on the work programme that anybody wishes to raise? Joe?
COVID hasn't gone away. But so I mean, we can't just use it sort of like, oh, the excuse because, oh, we haven't been able to do this since COVID. But I still feel that it is a vital part to actually consider, along with the actual financial constraints that all services are, is when I read things about pay awards being there, and then we look at sort of, oh, we're told that care staff can earn more in retail, etc. That to me doesn't make me feel comfortable, because it's as if to say the staff are to blame for some of the constraints because they've got a pay award.
Yes, we can discuss that a wee bit further, perhaps. Etra?
Yeah, I'd actually support Councillor Lawson in the sense that I think we need two golden threads. So I think COVID needs to stay there, and then the financial sort of implication of, you know, services and cost of living and all of that needs to go side by side, because I think one of the big things that COVID has done is impacted that financial side. And particularly with winter pressures, I think COVID comes in surges, and we are expecting that surge. So it'd probably be sort of naive of us to remove it completely and then maybe reinstate it.
I don't think I'd like to call myself naive, thank you, Councillor. We actually have 4 golden threads as it is. We've got workforce recruitment and retention. We've got impact of COVID-19, and it's just impact, and there's no impact now. Performance data to be included where appropriate to and inequalities in health, which will include checking the work being done to promote range of services and such like. Now, my point is that COVID has not got a large direct impact as of now. But finance has got a great deal.
Can I make a suggestion? Is that all right? I would think naturally a lot of the reports that will be coming on the work programme that we've got anyway, I can't imagine any of the partners that were coming that wouldn't highlight specific areas of concern in terms of COVID. I don't think they're going to miss that off any of the reports that come. So I think it's probably just a little shift, and it is supposedly probably an addition in terms of the budget pressures. And again, I don't really think they wouldn't come without telling us what the budget pressures were either. It's just, you know, I do think they will bring the COVID through. However, you know, if you do want an additional one, then we can, depending on what everybody feels, add that additional one.
Yeah, I think the point, we're not ignoring COVID, not saying COVID has vanished, it hasn't. But it's not the massive impact it was 3 years ago. It's much, much reduced since 2021, 22. It's much reduced since then. That's all I'm saying. But I think it makes more sense now to focus as a golden thread on finance, on economics. Nobody's saying ignore COVID, but COVID is not the force it was 3 years ago. That we do need to appreciate. Anyone else?
I suspect actually they probably are inexplicably, isn't they? Inextricably linked anyway, the two together, as reports come through.
Yeah. But not saying COVID is vanished.
Councillor
Smith. Yeah, I think.
Yes, Councillor Smith.
Yeah, I think looking at your work programme, the subjects that you have on your work programme, as Lundy has said, finance and other pressures, COVID as well, will form part of the narrative that comes in as part of these subjects. And therefore I think it's important that the whole of the narratives come in so that we get the whole picture of all the pressures, etc., that are being faced across the health and social care system, because as we know, if one part of the system is pressurised, then other parts of the system suffer, etc. And if they're all pressurised at the same time, then that is extremely difficult. So I think if you're looking at your subjects, then you may be wanting them to bring everything that is a pressure as part of that narrative, I would suggest. And that is whatever is affecting them at that time. Yeah.
Yes, thank you, Councillor Smith. I've not heard any health providers complain about issues arising from COVID now. Not saying they might not happen in the future. Viruses can come back. But the economic situation, I don't think, is going to improve overnight. I really don't. Councillor Adder.
I was just thinking that obviously the economic backdrop in which everybody's working is part of many of the golden threads, really. You know, it's performance data will reflect the impact of the economic crisis. Workforce recruitment and retention will reflect that, and the cost of living crisis. So maybe all the golden threads are really working underneath that banner of the economic picture at the current time. I don't know if we can't add it in somehow like that, so that it's reflected in everything that people, these need to be reflected in everything that they come back with. I don't know whether it's possible to add it into those in a way that it's the backdrop that everybody's working on and working in at the moment.
I think, let's not get hung up on this, but COVID is yesterday's news. The economy is today's news. Now, COVID may resurge, we don't know. But we have more people dying of winter flu than we do of COVID, certainly. There are other issues. COVID is getting a little bit out of proportion, is my view. Joe?
I think if you go to look at, say, the terms of winter pressures on hospital admission beds, you will find that there will be COVID patients in there. You'll find that there is a lot of respiratory conditions that end up with hospital admissions. As I said, it hasn't gone away. It is yes to the general public, it may be yesterday's news, but for the people having to staff COVID wards, it isn't.
Yes, that's fine, but you're making the point that winter flu is a big issue, but we don't have a golden thread of winter flu, do we? We don't have a respiratory tract infection golden thread. COVID is there, but it's just part of a much bigger package of general health issues. And all I'm saying is I don't think it perhaps qualifies as a golden thread now. But we are absolutely, some partner agencies are in danger of being overwhelmed with economic pressures. And I do think we need to pay very, very careful attention to economic pressure.
I'm not actually disagreeing with the economic pressures. Of course, they should be a golden thread. Is if you look at sort of the funding for the resources available for adult healthcare and social care and for the NHS, there is definitely a problem with resources there and their actual funding sources. I don't think anybody on this panel wouldn't actually agree, would not disagree that there is a need to look at the economic situation, especially with sort of high inflation rates, the utility rates that are being charged to sort of the NHS, to private healthcare providers as well. But I feel that the two of them could actually be interlinked.
Right, Councillor Addy.
Initially, I came to the panel and the impact of COVID-19 was already on there, and I can see why it would be on there. I don't know if you want in mind to take back to why it was put on there in the first place, but for me, I do think there will still be impacts. There's long COVID, there's the impact of isolation on health, and way people have changed how they work and how they behave, how they work in health terms, outside of actually having COVID. Is there a limit on the number of golden threads? I know you mentioned getting tangled, but you know that overarching, all of these could be seen in the light of the current economic state, and maybe that's just sort of something that's put into the package of golden threads, maybe.
Yes, perhaps. I mean, my point, and I'm losing this argument, that's fine. My point is that we don't hear people coming to us now and saying we've got awful pressures because of COVID. It's not an operational issue for providers, that's all I'm saying. I think we'll move on. We'll not change the golden threads, we'll keep them as they are. Not going to push, no point in pushing it. It's not a big argument, it's not something that's worth arguing about. So we'll just leave that. Have we got anything to pick up on the work programme, Yolanda?
No, I think that they've more or less been covered in terms of what you want to bring in future in terms of some of that information about virtual wards and things like that. I've absolutely noted that. So yeah, that can be woven into what we've got already.
Thank you. Panel, anything you want to say about the work programme? Anybody? Okay, well, thank you very much for your time. It's been quite an intense session and well done, and thank you very much. Bye there.